content are to the posterior wall, then it is towards the deep ring, then it is coming to the superficial ring. It is called as direct hernia. Few points about testes. Okay, so testes main one present on the scrotum, which are bilaterally present related to the lumbar region. Nothing to be of like they okay, so we'll be having this is the epidermis. The parts are head, body, tail. These are the parts of epidermis. So the sac or the space present between the testes and the epidermis is called the sinus of epidermis. It is called sinus of epidermis. So remember, related to MCQ, I'll be telling what are all the layers of testis: tunica, albuginea, vasculosa, and vaginalis. So there are three layers which are covering the testis. We know hydrocele is the commonest pathology of the scrotal swelling. So by that time, you should know what are all the three layers which are covering the testis: tunica, albuginea, vascularis, and vaginalis. So these are the three layers. And the blood supply, as the name indicates, testis, it is from testicular artery, which is from the posterior abdominal wall. As we already discussed, spermatic cord contains testicular artery. That represents it should enter the deep inguinal ring. It travels the inguinal canal, out of the inguinal ring, then it comes to the testis. Again, I said pamphiliform plexus. Am I right? So because the body temperature to be, if it is within the body, spermatogenesis is not possible. That's the reason why the testis is outside, right, towards the environment. So it is not a single lumen of vein which is draining the testis. Region wise, we saw brachial artery, brachial vein, radial artery, radial vein. But from the abdominal. But numerous tiny veins which emerges from the upper surface of the testis called as pamphiliform plexus. The plexus is called as pamphiliform plexus. They reunite to form a single vein at the level of deep inguinal ring only. You understand? So till deep inguinal ring, you'll be having minor branches to maintain the temperature. It is not a single lumen. So right testicular vein and left testicular vein. Being right testis, left testis. What is the blood supply? Testicular artery, which arises from abdominal aorta. Abdominal aorta. Venous drainage is important. Right testicular vein, left testicular vein. The drainage differs. Right testicular vein drains into inferior vena cava, whereas left testicular vein will drain into left renal vein. Left renal vein. This is important. Have you heard of nutcracker mechanism? Nutcracker, I will discuss along with the left renal vein. Why it is nutcracker mechanism? Left renal vein. And lymph nodes that drain into para-aortic and pre-aortic. These are all important for MCQ. Pre-aortic and para-aortic group of lymph nodes which drains the testis. Testicular vein, right side drains into inferior vena cava. Left side drains into left renal vein. Left renal vein. Now, regarding peritoneum, there are so many peritoneal folds present on the abdomen. Okay, so remember, liver, intestine, stomach, those are all the structures that are present on the abdomen and pelvis. Now you see the peritoneum is not invading into the pelvis. They are just reflected over the upper surface of the pelvic viscera. Am I right? So at that area they form pouches. We'll come to the pouches later. Now we'll see what are all the peritoneal folds that are present on the abdominal cavity. The peritoneal fold, which is hanging from the greater curvature of the stomach. This curvature is called as greater curvature. This curvature is called as lesser curvature. This is the upper end of the stomach called as cardiac end. This is the lower end of the stomach called as pyloric end. Pyloric end. Cardiac end. Pyloric end. The peritoneal fold hanging from the greater curvature, that fold is called as greater omentum. That is called as greater omentum. You will be having 4 layers of omentum. Now, first layer, second, it descends down. The first layer becomes the 4th layer. The second layer becomes the 3rd layer. You understand, right? As such, it is 2 layers hanging down from the greater curvature. It is coming down. Once it covers the intestine, The first layer becomes the fourth layer, second layer becomes the third layer, and it is attached to the great curvature of stomach. Now you see this fold. What is this? Liver. So the structures entering and exit through the liver is called as porta hepatis. That area is called as porta hepatis. Now you see the fold which is extending from the lesser curvature of the stomach towards the porta hepatis of the liver is called as lesser omentum. It is called as lesser omentum. Now you see this part of the lesser omentum is not attached. So this is called free margin of lesser omentum. This is the attached margin of lesser omentum. So what is the extent of lesser omentum? It extends from lesser curvature of stomach to the porta hepatis. This margin is called as free margin. Now you see on the free margin, these structures are present. Common hepatic artery, while both are anterior. Posteriorly, it is portally. The structures that are present on the right free margin of the. So this is the right margin. If I am standing like this is my right. This is the left. So this is the right free margin of lesser omentum. This is the left attached margin of. This is attached margin. This is free margin. On the free margin, anteriorly two structures. This green color one is the bile duct. Left side is the hepatic artery. Posteriorly it is portal vein. These are the three structures that are present on the right free margin of the lesser omentum. Lesser omentum. So remember there is one more sac. I shown some other picture. Time being you remember. What is the space present in front of the stomach is called greater sac. What is present behind the stomach is called as greater sac. Now there is a foramen here, right? This is called foramen of Winslow, otherwise called epiploic foramen. Otherwise called as epiploic foramen. That is the communication between the only communication between on the abdominal cavity between the greater sac and lesser sac. That foramen here, right? If my finger is passing behind this blue portal vein, I am putting my finger on the lesser sac. If it is, I am keeping my finger here, it is on the greater sac. You understand, right? What is greater? Something, the space present behind the stomach. Once you take off the stomach and see, you can see the lesser sac. Unless otherwise, you cannot see it. Next is mesentery. The fold of peritoneum. See on the picture, the fold of peritoneum, which is holding the coils of intestine, right? Coils of intestine is called as mesentery. It is called as mesentery. It is called as mesentery. What is attached? Remember, one end of the mesentery is attached to the coils. The other end is attached over the abdominal wall. So it has a attached margin towards the abdominal wall. One end on the intestine. What is attached on the abdominal wall? It is root of mesentery. It is called root of mesentery. Root of mesentery. The root of some structures in order. These structures are that you have to remember. Structures crossed by root of mesentery are number one is third part of duodenum. Third part of duodenum. Duodenum has how many parts? Four parts. First part, second part, third part, and fourth part. So it crosses from left to right. The root of mesentery extends from left to the right. These structures are third part of duodenum. Abdominal aorta. Next structure is abdominal aorta. Next is right ureter. Next is right ureter. Next one is right psoas major muscle. Right psoas major muscle. So these are the structures that are crossed by mesentery. You understand, right? Mesentery is a fold of peritoneum holding the small intestine. Next is falciform ligament, right? Can you able to see this separating liver into right and left? This is the right lobe, this is the left lobe. So on the center you get a fold of peritoneum extending from the umbilicus to the anterior. This surface of the liver is called anterior surface of the liver. So that fold of peritoneum extending from the umbilicus going posteriorly towards the anterior surface of the liver is called as falciform ligament. Falciform ligament. Falciform ligament which is present on the anterior surface of the liver. Next, transverse mesocolon, right? We know the parts of large intestine, which starts from cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and colon. So, peritoneal fold, what has been attached to the transverse colon is called as posterior surface of the transverse colon is called as transverse mesocolon. Transverse mesocolon that separates the abdomen into supracolic compartment and infracolic compartment. What is present above the attachment of the transverse mesocolon is supracolic compartment. What is present below is called as infracolic compartment. Supracolic and infracolic. What is present in front of the stomach is what sac? Greater sac. What is present behind the stomach is lesser sac. What is the communication between the lesser sac and the greater sac? Epiploic foramen. The foramen is epiploic foramen, right? This the communication between the greater sac and lesser sac. The structures present on the free margin are bile duct, hepatic artery, and portal vein. Portal vein. Now you see this. This blue color area is the greater sac. Area is the lesser sac. Nowhere else you get communication here, right? That is otherwise called omental bursa. It is otherwise called as omental bursa. Only at this side, right? You get an arrow here. That is on the right free margin. That opening is called as epiploic foramen. That foramen is called as epiploic foramen. Next is stomach proper. This you are all familiar, right? Cardiac end, pyloric end, lesser curvature, greater curvature. The parts of the stomach are fundus, body, pylorus. It is divided into a pyloric antrum and pyloric canal. So location of the again you get a physiological sphincter on the cardiac end and an anatomical sphincter on the lower end. So proper sphincter is on the lower end. Only anatomical sphincter, physiological sphincter by the supply of the vagus nerve you get the sphincteric action. Thereby the regurgitation of the food from the stomach is prevented into the esophagus. And this is the more what does fundus contain? Fundus contain normal content. Air. It contains whenever you eat, small amount of air enters into the stomach. That can be seen as a radiolucent shadow on a normal radio. Okay, translucent shadow. Now, see on the picture for angularis incisuris, the most dependent part of lesser curvature is called as incisuris angularis. Can you see on the picture? To trace the lesser curvature, the most dependent part is called as incisura angularis. Incisura angularis. So, what is the peritoneal fold related to greater curvature? Greater curvature. Greater omentum. Lesser curvature. Lesser omentum. Cardiac orifice. See on the picture alone, you should know at which level it is present. It corresponds to the left seventh costal cartilage. It corresponds to left seventh costal cartilage anteriorly. Posteriorly, it is related to T11. T11. That to be only two things you have to remember. It doesn't have anatomical sphincter. Two levels you have to live. This is theory purely. Something like maths, you remember. Anteriorly, it is related to left seventh costal cartilage. Posteriorly, it is related to T11 vertebra. Next, pyloric orifice lies at L1 that corresponds to ninth costal cartilage. Ninth costal cartilage. That is T11. This is L1. 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 One more thing. The lower end by means of a vein called pre-pyloric vein of Mayo. We identify the vein, thereby we approach the stomach. Lesser curvature is related to which what fold? Lesser omentum. You see there is an artery on the lesser curvature, right? Two arteries are present, left gastric artery and right gastric artery. Two arteries are related to lesser curvature. Right and left gastric arteries are related, structure related to lesser curvature are two arteries, left gastric and right gastric. Now you see on the greater curvature, again two arteries and and left gastro epiploic artery, right and left gastro epiploic artery, right and left gastro epiploic artery. So remember, on the lower end of the pylorus there is one important vein called as prepyloric vein of Mayo. Prepyloric vein of Mayo. So what does stomach secrete? Gastric juice. So you should know the name of the cells that are present on the stomach. So what are all the cells you know? Chief cells, parietal cells, chief cells, parietal cells. Parietal cells is otherwise called as oxynetic cells. Parietal cells are otherwise called as oxynetic cells. OXYNTIC. Oxynetic cells and G cells and G cells. These are all important. Okay. So which side of stomach is prone for ulceration? Lesser curvature. Why? Remember again, the solid food passes into the body, whereas the liquid food enters the lesser curvature. Okay. As muscularly present, you get the horizontal fibers are absent on the lesser curvature. That's the reason why the liquid food is passing through the lesser curvature, and that is more prone for ulceration. Okay. So that is very important. Let's play. Already how many arteries we saw now? 4 artery, right and left gastric artery, which is present on which curvature? Lesser curvature. Right and left gastroepiploic artery, which is present on which curvature? Greater curvature. The lymph nodes are. It's very clear on the picture. Along the lesser curvature, pancreatico-splenic group of lymph nodes. Along the greater curvature, you get right gastroepiploic group of corresponding artery, corresponding lymph node. Ultimately, at the level of pylorus, pyloric group of lymph node. Above the pylorus, hepatic group of lymph node. This is important when you go for resection of stomach during gastrectomy in a case of gastric carcinoma. Okay, so by the time you should know what are all the lymph nodes fundus drains into, body drains into, pylorus drains into, greater curvature likewise you have to read. Okay, specific site, specific lymph node. This is very, very important. Okay, next is gastric triangle. The part of the stomach which is in contact with the anterior abdominal wall is called as, that ash color area is called as gastric triangle. It is called as gastric triangle. Gastric triangle. Next is trop space. It is obliterated in hepatomegaly, splenomegaly, and pleural effusion. See on the picture, we'll trace the trop space where it is. Can you locate trop space? That green color line at the level of the costodiaphragmatic recess of the 7th rib, right? That space is called as trop space, where we put the gastrectomy tubes for the feeding of any patients. Okay, if you want to put any drainage tube, that to be kept on the trop space. That's the clinical importance of trop space. Stomach bed. As we know, what is the sac in front of the stomach? What is the sac in front of the stomach? Greater sac. What is the sac present behind the stomach? Lesser sac. Am I right? So once you, on this picture, you can see the stomach or not? No, you cannot see the stomach. Am I right? It has been taken off. So stomach is resting on a structure. When you eat, the stomach is expanding, right? It is allow uniform expansion. Once the emptying of the stomach occurs, it is again coming back to its normal position. Am I right? So whenever you eat, the position varies, right? So it is lodged on some structure. Those stomach bed. These structures are transverse mesocolon down. Can you able to see transverse mesocolon? That is the first structure. Lowermost structure. Here is transversely present. Transverse mesocolon. Just above the transverse colon, what is present? That lobulated yellow color structures are pancreas. Pancreas. It is pancreas. Just above the pancreas, an artery is running. That artery is splenic artery. The artery is splenic artery. Now you trace little towards the left side, left kidney and spleen. Left kidney and spleen. So these are the structures that forms stomach bed. Stomach bed. This will go in development. Okay. This I am skipping. Now coming to the parts of the duodenum. Duodenum is related. How many parts? First part, second part, third part, fourth part. There are 4 parts on the duodenum. What is present on the C-shaped concavity of the duodenum? What is present? What it lodges exactly? What organ you expect? See this. On the C, what is present? Pancreas. Pancreas is present on the C-shaped concavity of duodenum, which is an endo and exocrine gland. It is both endo and exocrine gland. So now you see at the level of second part, what are all the artery present? This vertical part is the second part, extending from above downwards from L1 to L3 vertebra. So that is the second part, which is related to superior pancreatico-duodenal artery and inferior. It's very clear on the picture, right? 2 arteries are anastomosing at this site. Superior pancreatico-duodenal and inferior pancreatico-duodenal. So first part is the superior part, second part is the descending part, third part is the horizontal part, and fourth part is going above, right, which is the ascending part. So what is the total length of duodenum? Total length 20 to 25 centimeter. 20 to 25 centimeter. Again I said the fold of peritoneum which is holding the small intestine is mesentery. So it is, but duodenum is not so. It is not holded by mesentery. Only jejunum and ileum is holded by mesentery. Duodenum is not holded by mesentery. Then what do you expect this to be? What are all the structures that opens on the duodenum? Bile is produced on the liver. It comes out of the liver through the duct system. Then it comes out as the hepatic duct. So it should open on the second part of duodenum. Again, pancreatic enzymes are secreted. Pancreatic juice is secreted. Again, that should open on the duodenum. So 2 structures opens on the duodenum interiorly. One on the major duodenal papilla, one is the minor duodenal papilla. So there are 2 openings on the duodenum. Major duodenal papilla, minor duodenal papilla. Major and minor duodenal papilla that opens on the second part of. There are 4 parts of which the structure is opening only on which part? On second part alone. Second part alone. What gland you can see on the duodenum? Brunner's gland. The glands are Brunner's gland. This is the way difference between this theory. Should I take? Shall I skip off? Shall I tell the salient points? So to differentiate small intestine and large intestine. Small intestine has villi for absorption. Large intestine doesn't have villi. And there are 3 parts here. There are so many parts. Cecum, ascending colon, descending colon, likewise. Okay. So remember, small intestine. At some places you may have a lymphatic follicle collection called as Peyer's patches. On the ileum we have Peyer's patches. That is the a lymph place where you get typhoid fever. The salmonella is commonly lodged on Peyer's patch. If it is involved, that is called a typhoid fever. So that is present on the small intestine, which is not present on the large intestine. These are these 2 and caliber. Small intestine will be small, large intestine is larger. Since water to be Absorb. All the nutrients are absorbed from the intestine, but water absorption is taking place on the large intestine. Large intestine. This you are familiar with the picture, right? On the center of this, right? Can you see a thickened membrane? On you concentrate on ascending colon alone. On the center, first you see large intestine or saccules, right? It is something like sacculations. Am I right? First point to identify large intestine is it is sacculated. It is sacculated. Now you see on the center there is one more longitudinal fiber that are concreted, which are starting from the cecum, not from the appendix. Am I right? Cecum is above, below it is appendix, but that fold is starting from cecum and it is traversing towards transverse, descending, extending till the sigmoid colon. That is called tinea coli. That is called as tinea coli. Tinea coli. Fatty globulets here and there. Am I right? The muscular fold is on the center. First is circulation. Now on the center you get a longitudinal muscle that is called tinea coli. Tinea coli. Now you see there's one more fatty substance here and there, right? Some lobulated structure that we call it as appendices epiploicae. Appendices epiploicae. That we call it as appendices epiploicae. Up to this clear, right? Parts you are clear, right? So now what you have to remember is I said that muscular cord not right? So once we open the abdomen for appendectomy, we cannot see the appendix. It is present posterior to the cecum. Retrocecal is the commonest position of the appendix. By the time you have to hold the muscular fold first. We trace it downwards towards the appendix. At one point, the muscular fold as will be disappearing. That represents I have reached the base of the appendix. That is the twig where the appendix is attached to the cecum. Is it clear? You have to put the finger on the longitudinal cord, trace it downwards. We trace it downwards. At one point, the muscular fold will disappear. That represents I have reached the base of the appendix. Then the twig to be ligated at this site for appendicectomy. That's the first step a surgeon should know during appendicectomy. Is it clear? Next, these are the commonest positions of the types of cecum. This is the adult type, infantile type, fetal type, and exaggerated type. These are the various types of cecum. Now, once you take off the cecum, you can see the cecum is resting on this structure. As we studied stomach bed, right? For cecum, here it is posterior relations of the cecum. Can you see an outline of the cecum which has been marked on the black color? That is cecum. So cecum is resting on a muscle called iliacus. That muscle is iliacus. Next muscle is psoas major. Psoas major. What is the artery it is running? Iliac branch of ilio-lumbar artery, and the nerves are, what are all the nerves present within that black color? Lateral cutaneous nerve of thigh, femoral nerve, genitofemoral nerve. So how many nerves are present? 3 nerves. Name the artery. External ilio-lumbar artery. The artery is ilio-lumbar artery. Ilio-lumbar artery. Ilio-lumbar artery. So what opens? Now you see terminal part of ileum. Am I right? Terminal part of ileum. That is opening on cecum. So what opens on cecum? Ileum. What opens on cecum? Ileum. Small intestine, duodenum, jejunum, ileum. Ileum opens on cecum. The content of the small intestine is pushed into the cecum. So you should have a valve at that side. The valve or the orifice is called as ileocecal orifice. Ileocecal orifice. Now you see on the picture there is a fold of peritoneum called mesoappendix. Can you able to see mesoappendix? A fold of peritoneum extending from the terminal part of ileum to the appendix. That is called as mesoappendix. That is called mesoappendix. And the blood supply to the appendix is through appendicular artery. We'll see from where it comes. Appendicular artery. Thing to be remembered is it is an end artery. What is end artery? It doesn't have any other anastomosis with further artery to ramify its circulation. That is called end artery. So if it is necrosed, it is permanent damage. That's the reason why we do appendicectomy. Okay. So these openings. So there are two openings. Ileum is opening on the upper part. Appendix is opening on the lower part. Positions of the appendix. There are various positions. 64% of the patients will be having it is retrocecal. It is retrocecal. So 0.5 splenic. Next, 1% is pre-ileal. 32% is promontory. Is it clear? The 5 positions of the the commonest position is that is important. Commonest position will be asked in MCQ. It is retrocecal. Retrocecal. And now you see that yellow color structure. Can you able to see this? Terminal part of ileum below the ileum connecting the appendix. That fold of peritoneal fold is called as mesoappendix. What runs on mesoappendix? Appendicular artery. What runs on mesoappendix? It is appendicular artery. Appendicular artery. This is very important. The fold of peritoneum holding the terminal part of ileum and the appendix is called as mesoappendix. Now, McBurney's point. What is McBurney's point? Now you draw a line from the anterior superior iliac spine into umbilicus. This is the area where the maximum tenderness of appendicitis is present on the surface of the anterior abdominal wall. Is it clear? You divide the line into lateral 1/3 and medial 1/3. The junction of that is it is not corresponding to the surface marking of the appendix. Once you open this area, you cannot see. Once you open, you trace from the tinea coli, you trace it down, that represents base of appendix. That is entirely different. This is not the surgical marking. This is the area of maximum tenderness over the anterior abdominal wall where we clinically elicit the tenderness of the appendicitis. The junction between the lateral 1/3 and the medial 2/3. That is called McBurney's point, which we call it as abdominal tonsil. Abdominal tonsil. The mucosa, what is present on the appendix is called as abdominal tonsil. You get lymphocytes collection on the GIT. Am I right? Malt associated malt, MALT, malt associated lymphoid follicles. At the level of the oral cavity, we have lingual tonsil, palatine tonsil, tubal tonsil, pharyngeal tonsil. Likewise, those collections are present on the ileum as Peyer's patches. That is called as, so one above, one below. Guarding the GIT above and below, we are well protected. Am I right? We eat so many things, but the infection is not common. Every day we are not getting infection. Am I right? Unless otherwise some bacteria is present on the contaminated food. Am I right? Diarrhea is not frequent, right? It is very rare to us. Am I right? We are eating an hygienic food, right? If not, if the malt are not present, whatever we eat, we have constant diarrhea. It is not so. It is because of the malt which is present above and the Peyer's patch which is present on the ileum. Is it clear? The next is liver. So transverse colon, what is the peritoneal fold which is attached to the transverse colon? Transverse mesocolon. Transverse mesocolon, which divides the abdomen into a supracolic compartment and infracolic compartment. Supracolic and infracolic compartment. Is it clear up to this? Stomach, we saw the parts of the stomach, folds attached to the stomach, artery related to stomach, and lesser omentum, epiploic foramen, lymph nodes draining the stomach, parts of small intestine, first part, second part, third part, fourth part, artery related to the C-shaped concavity, head of pancreas is lodged on it, and structures opening on the second part of duodenum. Then jejunum and ileum. The peritoneal fold holding the small intestine is called mesentery. What is attached to the posterior wall of the abdomen is called as root of mesentery. It crosses some structure from left to the right. Is it clear? Then we saw the parts of small intestine, large intestine in order, cecum, types, and there are some 4 points to identify the large intestine: sacculation, tinea coli, appendices, epiploicae. Then appendix, the peritoneal fold related to appendix. What are all the various positions of the appendix? What is the blood supply of the appendix? And what is McBurney's point? Up to this we have completed, right? Next is major organ, liver. So liver has how many lobes? 2 lobes, right lobe and left lobe. What is present on the center? Falciform ligament, which divides the liver into a larger right lobe and a smaller left lobe. This surface of the liver is the anterior surface. The surface is anterior surface. What is present above the liver? Thoracic cavity. So it is separated by diaphragm. So diaphragm separates the liver from the lung. So superior relation is diaphragm. So remember, the outer covering of the liver is called as Glissen's capsule. The capsule is called as Glissen's capsule. The capsule is called as Glissen's capsule. Now you trace the falciform ligament above. It is diverging to the right side and left side as coronary ligament. As coronary ligament. And this is the inferior surface and this is the posterior surface. Now you see on the posterior surface, on the center, you get one more fissure, right? That fissure is called fissure for ligamentum venosum, that blue colored marked structure. Fissure for ligamentum venosum. Now porta hepatis, can you able to see there is one port, the structure that enters and leaves the liver is entering to the hilum. We say hilum for kidney. We say hilum for lungs. Here it is called porta hepatis. Porta hepatis. We'll come to porta hepatis later. So anteriorly it is falciform ligament. Posteriorly fissure for ligamentum venosum, which largest ligamentum venosum. Trace it down. Can you able to see one more white color rounded structure just lateral to the gallbladder? That is called ligamentum teres. Ligamentum teres. So from anterior to posterior, 3 ligaments divides the liver into how many lobes? 2 lobes. Like falciform ligament anteriorly, you trace it posteriorly, it is ligamentum venosum. Lower down it is ligamentum teres. Ligamentum teres. Now lateral to, just towards the left of the inferior vena cava, there is one space. Am I right? That lobe is called caudate lobe. That lobe is called caudate lobe. Lateral to gallbladder, there is one more space. That lobe is called caudate lobe. That lobe is called caudate lobe. That lobe is called as caudate lobe. Now you trace on the picture towards the right end. You get bare area. Am I right? Bare area of the liver. What is bare? Not covered by peritoneum. Whole of the liver is covered by peritoneum. At one side, the liver is not covered by peritoneum. That area is called as bare area. That area is called as bare area. That represent, it should have a boundary. Am I right? Now you see on the picture, above and below by anterior coronary ligament. Am I right? The boundary of bare area. Can you able to see this? See on the picture, you trace falciform ligament towards the right side and left side, it is coming as coronary ligament. Coronary ligament. Trace on the left side, coronary ligament continues as on the left side. Left triangular ligament. Left triangular ligament. Same way, the coronary ligament, what is going towards the right side, is splitting as 2 layers as anterior layer and posterior layer, only on the right side, not on the left side. What is found on the left side? Coronary continues as left triangular. So after enclosing the bare area as anterior coronary and posterior coronary, they unite to form, see on the picture, they unite to form right Triangular ligament, right? Triangular ligament. So that is the boundary of bare area. Am I right? It's very clear, right? Anteriorly by anterior coronary ligament, posteriorly by posterior coronary ligament, on the right side by right triangular ligament. So what we expect is, why it is bare area? We have hepatic veins within the liver. So many veins are present on the liver, which in communication with the vein of the diaphragm. Direct communication. Since peritoneum is absent, so any abscess of the liver can retrogradely perforate into the thoracic cavity through the inferior diaphragmatic veins. So that is called as bare area of the liver. I said how many two more lobes? Caudate and quadrate. Caudate and quadrate. So to the right of the caudate lobe, what structure is present? Towards the right, inferior vena cava. To the left, what is present? Groove for ligamentum venosum. What is present below? Porta hepatis. Above it is the superior surface. So that is the boundary of caudate lobe. Boundary of caudate lobe. Now you see on the same picture, there is one sharp border of the liver. That border is called as inferior border. There is only one border of the liver. It is called as inferior border, which extends from left to the right. Extends from the left to the right. Now you see caudate lobe. What is present right to the caudate lobe is right to the quadrate lobe. Quadrate lobe. What is present? Gallbladder. What is present to the left is ligamentum teres. What is present above? Porta hepatis. Now you see on the picture for porta hepatis. What are all the structures that are present on the porta hepatis? Portal vein is entering, right? All your absorbed food materials from the intestine should be metabolized. Am I right? It is carrying all the nutrients to be stored as glycogen into the liver through portal vein. So first structure is portal vein. So 80% of the blood supply of the liver is through portal vein. Though it is a vein, it carries all the nourished material along with a small deoxygenated blood. So main blood supply 80% is through portal vein, 20% is through hepatic artery from the celiac trunk. It arises from celiac trunk. One more green color structure is coming out of the liver. It is hepatic duct. It is hepatic duct. How many lobes for liver? 2 lobes. So from each lobe, one duct will come. It is the right and left hepatic duct. Right and left hepatic duct comes out of the liver. Remember, bile duct form. Though it is the formation of the bile is on the liver, bile duct formation is not within the liver. Be clear. On the MCQs, this is a major mistake what everyone do. Being bile, the formation of the bile is not within the liver. It is formed only outside the liver on the right free margin of the lesser omentum. Is it clear? 2 hepatic duct comes out of the porta hepatis. They unite to form common hepatic duct. That common hepatic duct joins with the cystic duct of the gallbladder to form bile duct. Is it clear? 2 hepatic duct unite to form common hepatic duct. That common hepatic duct contains bile. Now bile to be concentrated. From there it reaches the gallbladder. Concentration takes place. They come out of the gallbladder again through cystic duct. So the duct of the gallbladder is cystic duct. So hepatic duct from the liver, cystic duct from gallbladder unite to form bile duct. That bile duct opens on the second part of the duodenum on major duodenal papilla. Already I said you, right? 2 structures opens on the second part. One is from the pancreas, one is from the duodenum. You understand, right? This is very, very important. Okay. So bile duct formation is outside the liver. Be clear. Though the content is bile, obviously we accept it, but the formation is outside. 80% of the blood supply of the liver is through which vein? Portal vein. 20% is through hepatic artery. So we finished caudate lobe. Once again, I'll repeat. We finished caudate lobe, quadrate lobe, structures present on the porta hepatis. We finished what is bare area. Okay. So this surface of the liver is what surface? Anterior surface. This surface is inferior surface. This surface is posterior surface. There is one more surface called as right lateral surface. Right lateral surface. This surface is right lateral surface, which is related to the costal margin. Now you see what is above. You say diaphragm is above. So during pleural effusion, care to be taken not to put the needle below the 7th costal cartilage, because 7, 8, 9, 10, 11, 12 costal cartilage will be towards the dome of the diaphragm. So when you do a pleural effusion below 7th costal cartilage, you should not ascend up. If so, you are endangering directly into the diaphragm, that may cause respiratory paralysis. That to be considered as 7th costal cartilage, you keep on mind. And you read the right lateral relations of liver. That is very important. Right lateral relation. When you go through liver, right lateral relation to be memorized. Right lateral relations of the liver. Next, the components of the extrahepatic biliary apparatus. The components are gallbladder. The duct of the gallbladder is cystic duct. Right and left hepatic duct unite to form what duct? Common hepatic duct. Cystic duct joins with the common hepatic duct to form what duct? Bile duct. So this course you should remember. Now you see the parts of gallbladder. The parts are fundus, body, neck, and the ductus, cystic duct. Now you see on this, can you see gallbladder fully or not? No. So a small part of the gallbladder, what has been protruding down from the inferior border, that is called as fundus. That is called fundus. That is called as fundus. And regarding surgical segment of the liver, you should know what is coordinate segment. So surgical segments are 8 in number. Okay, each segment of the liver is further divided into 8 functional segments. That we call it as coordinates classification. That you have to read. So what is the covering of the liver? The capsule is called as Glissen's capsule. Glissen's capsule. Structure will do with histology. Okay, space of Maltz, space of disease will deal in the histology of the liver. That I am skipping now. Can you see the fundus? It is at the level of right 9th costal margin. Okay. So where the referred pain of cholecystectomy is, you can feel. Referred pain. Right shoulder. Am I right? Because the phrenic nerve fibers, what is innervating the diaphragm is also innervating the right shoulder. That's the reason why we have referred pain. So what would be the, up to this you are clear, right? Now you see the structure from inner to outer. There are 3 layers. As GIT, it should have 4 layers, but muscularis mucosa and submucosa is absent. We should not have submucosa, because if it is present, it secretes mucus. But the function of the gallbladder is to concentration of the bile. We need a concentrated bile for which digestion? Concentrated bile is needed. Bile is needed for fat digestion, right? So unless otherwise the bile has been poured into the second part, digestion will not be possible. So what should act on the gallbladder? Pylorus and first part of duodenum secrete an enzyme called CCKP, is that right? Cholecystokinin pancreosamine. That should act on the gallbladder. That should be adequate. Then though the flow will be normal from the liver, it enters the gallbladder. Concentration will be there. But if there is no secretion of CCKP, is that there won't be expulsion of the bile from the gallbladder. If so, you get stasis of the bile within the gallbladder itself. That leads to cholelithiasis. Is it clear? So after cholecystectomy, we have to substitute the patient with CCKP enzymes lifelong. Am I right? Bile is not, you have removed the gallbladder. Am I just like that? Bile is coming from the liver. So that should be substituted by the alternate medications lifelong. Okay, so absence of muscularis mucosa and submucosa on the gallbladder. The pouch that is present on the cystic duct is called as spiral valve of Hestus, otherwise called as Hartmann's pouch. It is otherwise called Hartmann's pouch, otherwise called as Hartmann's pouch. Lower down cystic duct, some constriction and dilatations are present on the lowermost part, and that we call it as Hartmann's pouch. Hartmann's pouch. A common bile duct is divided into supraduodenal, retroduodenal, infraduodenal, and intraduodenal. Okay, can you able to see? You don't concentrate on the text part, you concentrate on the pictures. Okay, you see the gallbladder. The duct coming from the gallbladder is cystic duct. A duct from above is common hepatic duct. They unite to form the bile duct. See, the bile duct is traversing the pancreas on the posterior surface, that is opening on the second part of duodenum. Can you able to trace it? The pathway from liver till the second part of duodenum. The second part of the duodenum is exposed to see the interior. Can you able to see? And you see there is a duct arising from the pancreas on the center. Something is running on the center of the pancreas. That is the pancreatic duct, which is opening on the second part of duodenum. Next, have you familiar with this triangle of Callot's triangle? What is it? Trace the boundary first. Triangle of, it is bounded by common hepatic duct and hepatic artery. You get a lymph node called lymph node of Lund on the triangle. The thing to be remembered is we ligate the hepatic duct during liver transplant on the Callot's triangle. So that is the importance of Callot's triangle. Callot's triangle, it is bounded by hepatic duct and hepatic artery. It's very easy. Okay, a smaller triangle at the level of pedicle of the porta hepatis. See on the picture, common hepatic duct and cystic duct. Lymph node of Lund, L-U-N-D, Lund. Clinically, during liver transplant, you have to ligate the hepatic duct which has been emerging outside, right? So that pedicle to be ligated at the side. Callot's triangle. This is an ultrasound of liver where you get a trans opaque shadow on the center. A normal radiogram. Spleen. What is the function of spleen? Organ of reticuloendothelial system. Organ of reticuloendothelial system. Where it is present? On right side or left side? I said how many quadrants for the abdomen? Quadrants of abdomen, how many number? 9 in number. Divided by how many lines? 2 horizontal lines and 2 vertical lines. The 2 horizontal lines are transpyloric plane and transtubercular plane. So what is the region present on the left side above? The first region is left hypochondrium. So spleen is situated. So whenever you read any organ, you should know which quadrant of the abdomen it is present. You have to locate the organ where it is present. Spleen is a smaller reticuloendothelial organ which is present on the left hypochondrium. So this surface of the spleen is visceral surface. That surface is called as, this is visceral surface related to the organ. That is peritoneal surface or diaphragmatic surface. That surface is diaphragmatic surface since it is related to diaphragm. You know the dictum 1, 3, 5, 7, 9 to 11. Odd number dictum 1, 3, 5, 7, 9, 11. 1 centimeter thick, 3 centimeter breadth, 5 centimeter length, 7 ounce in weight. It is related to 9, 10, 11 ribs on the left side. 1, 3, 5, 7. Thickness, breadth. Normally we used to say length, breadth, thickness. Now you have to say in reverse. Thickness, breadth, length. 1, 3, 5. 7 ounce in weight. 7 ounce in weight. It is related to 9th and it is between 9 and 11th rib. The odd number sequence. for spleen 1 to 11. 1 inch thickness, 3 inch breadth, 5 inch length, 7 ounce in weight, and it is related to 9 to 11 ribs. So ribs are horizontal or oblique for us? Ribs are oblique. Ribs are oblique. Which is the longest rib? 7th rib. Which is the most oblique rib? 9th rib. You know the dictum now, right? How many surface is that? 2 surface, visceral surface and diaphragmatic surface. Now you see on this picture, spleen is more towards the left side. Am I right? Now you trace the pancreas from right to the left. It has head, neck, body, tail. What is related to the spleen is tail. Tail of pancreas is related to spleen. There is a ligament at that level called as lieno-renal ligament. Lieno-renal ligament at the level of tail of pancreas. Lieno-renal, which is enclosing the tail of pancreas, coming towards the anterior surface of the left kidney. So during pancreatectomy, what we have to consider is we have to separate the lieno-renal ligament and we have to preserve the tail of pancreas. Tail of pancreas, as it contain, what does it contain? More amount of beta cells which is going to secrete insulin. So during splenectomy, when you ligate splenic artery, resect the lieno-renal ligament which is related to the tail of pancreas in order to prevent the surgical induced diabetes mellitus. Since tail of pancreas contain beta cells, it contains beta cells. As we know, any opening is called as hilum. Any opening is called as hilum. So here what is present on this? Splenic artery, splenic vein, lymphatic, splenic nerves. Splenic artery is a branch of celiac artery. We'll see what is the fate of splenic vein later. Time being, remember, artery is entering, vein is coming out. Splenic artery is entering, splenic vein is coming out. And during malaria, what is the direction of splenomegaly? Normally, it is a left side organ. If it is enlarged, it should descend down towards the left. But it is not so. It is descending downwards towards the right side. Even till the right iliac fossa, on infants, you can feel the splenomegaly. So, what anatomical factor is present on the left side? So as the spleen is not descending, left side organ na kila da iranganum. Am I right? Hepatomegaly, it is full of on the right side, but left side organ is coming towards the right side. Why so? There is one more ligament called as phrenicocholic ligament. Phrenicocholic ligament, which extends from the diaphragm till the anterior surface of the splenic flexure. You get a turn from the transverse colon to the descending colon. Am I right? Transverse is continuing downwards as descending. So that flexure is called as left cholic flexure, otherwise called as splenic flexure. So a ligament extending from the diaphragm coming towards the colon called as phrenicocholic ligament, that acts as a chair for the spleen that will not allow the spleen to come down beyond the colon. We know the abdomen is divided into a supracholic compartment and infracholic compartment by transverse mesocolon. So already posteriorly transverse mesocolon is there. Now one more ligament is anterior to the spleen, phrenicocholic ligament. So you don't have sufficient space. The ligament will not allow the spleen to come down. It descends towards the left side. Is it clear up to this? So spleen, as you know the dictum, rib level. What two ligaments are you enumerated? Lieno-renal ligament, its surgical importance. Phrenicocholic ligament, its clinical importance. Why it is important? What is the blood supply to spleen? It is through splenic artery. It is through splenic artery, which is a branch from celiac trunk. Is it clear? It develops from dorsal. One word you remember, I'll explain it later. Frequently they will be asking, spleen is developed from dorsal mesogastrium. Dorsal mesogastrium. Spleen is developed from dorsal mesogastrium. What is this picture? Abdominal aorta. It extends from T12 to L4. The extent. Thoracic aorta continues as abdominal aorta, which divides into common iliac on right side and left side. Now you see some round circles are there, right? Anterior wall. So the anterior branches of the abdominal aorta in order from above downwards are number 1 celiac trunk, number 2 superior mesenteric artery, number 3 inferior mesenteric artery. Inferior mesenteric at the level of L3, superior mesenteric artery at the level of L1. Celiac trunk is between the intervertebral disc of T12 and L1. It is between the intervertebral disc of T12 and L1. You understand up to this? Ventral branches of abdominal aorta are from above downwards celiac trunk, superior mesenteric artery and inferior mesenteric artery. Now, lateral branches. Inferior phrenic artery, middle suprarenal artery, renal. Remember, arteries emerging from the lateral aspect of the lumen. Anteriorly 3 branches. Now we are tracing the lateral branches from above downwards. One is going towards the diaphragm, inferior phrenic artery. Next one is middle supra. We'll discuss. If there is a middle, there should be superior and inferior. We'll trace from where it comes later. Okay. Above and below. So what can be artery? So from inferior you get superior. From renal you get inferior. Vice versa. We'll trace along with the suprarenal gland. Time being, you remember. It's very easy remembering. You just erase the celiac trunk and superior mesenteric artery from the picture. Just imagine if celiac and mesenteric labeling is not there. Is it clear? Instead of from renal artery, an artery is ascending up, that is inferior suprarenal artery. Again, from inferior phrenic artery, an artery is descending down, that is called superior suprarenal artery. So suprarenal gland has how many arteries? 3 arteries. One directly from abdominal aorta, which is middle suprarenal artery. Remember, suprarenal artery has 3 blood supply. One directly from the abdominal aorta. The branch is middle suprarenal artery. If there is middle, there should be superior and inferior. That superior arises from inferior phrenic artery. The inferior arises from the renal artery. Where does renal artery supplies? Kidney, right and left kidney. Gonadal artery, if it is present in male, it is called testicular artery. If it is present in female, it is called ovarian artery. Gonad is common. Am I right? Already we saw it is a content of spermatic cord. Am I right? For male. For female, it is round ligament of uterus and ovarian artery, which is going to supply the ovary. Up to this, you are clear, right? We saw the ventral branches of abdominal aorta, the extent of the abdominal aorta. Terminal branch is right and left common iliac artery. This common iliac artery will divide into internal iliac and external iliac. External iliac will continue over the thigh as femoral artery. Okay. Celiac trunk on the center. Am I right? This we know, right? Left gastric, right gastric. We completed this already. Now you see this superior mesenteric artery. It is supplying which part? Right side or left side? We already know C-shaped concavity of duodenum is related to superior pancreatico-duodenal and inferior pancreatico-duodenal artery. So that is the blood supply of duodenum. Jejunal and ileal branches, that is going to supply jejunum and ileum. Now you see on the picture, superior mesenteric artery is going to supply the right 2/3 of the transverse colon. The area of supply, we know foregut, midgut, hindgut. Am I right? GIT is developed from foregut, midgut and hindgut. So the artery of the midgut is superior mesenteric artery. Artery of foregut is celiac artery. Artery of hindgut is inferior mesenteric artery. Inferior mesenteric artery. Foregut, midgut, hindgut. Foregut artery celiac trunk. Midgut artery superior mesenteric artery. So what is the extent of the midgut is till the right 2/3 of jejunum, ileum, cecum, appendix, ascending colon, right 2/3 of transverse colon. Up to that it is superior mesenteric artery. Superior mesenteric artery. Inferior mesenteric artery, hindgut. Lateral 1/3 of transverse colon or the left 1/3 of transverse colon. Descending colon. இப்பதான் வரீங்களா? இப்பதான் வரீங்களா? Left 1/3 of transverse colon, descending colon, sigmoid colon, rectum and anus. Up to this you are clear, right? Artery of foregut, celiac trunk. Artery of midgut, superior mesenteric artery. Artery of hindgut. So celiac trunk, superior mesenteric, inferior mesenteric are the ventral branches of abdominal aorta. All three arises from the ventral surface of abdominal aorta, going to supply the GIT structure, foregut, midgut and hindgut. Portal vein. So, what is portal vein? A vein, a specialized venous channel which carries the the absorbed food materials from the GIT to the liver for metabolism, right? Where we saw portal vein? On the free margin of lesser omentum. Lesser omentum, free margin, 3 structure. Anteriorly, 2 structure. Towards the left hepatic artery, towards the right bile duct. Posteriorly, portal vein. So 3 structures are present on 3 structures are present on right free margin of lesser omentum. Right free margin of lesser omentum. Now you see on the picture formation of portal vein. As we already discussed, transpyloric plane is related to so many structures in the beginning. Am I right? It is related to neck of pancreas also. Can you see neck over here? On the picture, tail is present, head is present, the neck is not present. So neck has been taken out to show the portal vein. Am I right? So 2 veins unite to form portal vein. You trace splenic vein from above, right? From left to the right, a vein is present. It is the splenic vein, a vein above, right? One is ascending above. That is the superior mesenteric vein. Superior mesenteric vein. So splenic vein joins with superior mesenteric vein to form portal vein. 2 veins unite to form portal vein. What are all the veins? See on the picture, splenic vein joins with superior mesenteric vein to form portal vein behind neck of pancreas. At the level is L1. It runs on which border of lesser omentum? Free border. Where the portal vein finally opens? On the porta hepatis of liver. On the porta hepatis of liver. You understand, right? Formation is on the abdomen behind the pancreas by the union of 2 veins. 1 vein from the spleen. I said hilum of the spleen is come from the hilum. 1 vein is coming out. It is splenic vein. And we know absorbed food material is on the small intestine that has been absorbed by, if this is a superior mesenteric artery, there should be a vein called superior mesenteric vein. It absorbs the food material. Now it should go to the liver. How it goes on its course? It joins with splenic vein to form portal vein. Then it runs on the right free margin. Then it opens on the liver as one for the corresponding lobe. Is it clear? For the corresponding lobe, it is entering. Now, what is present below the duodenum is the infraduodenal part. Infraduodenal part. What is present behind the duodenum is called as retroduodenal part. Retroduodenal part. What is present above the duodenum is called as supraduodenal part. So, there are three parts for portal vein. Infraduodenal, retroduodenal, supraduodenal. What is the function of portal vein? It is the main blood supply to which organ? Liver. Now you should know what is the portocaval anastomosis. You get communication of portal vein and this systemic vein at some areas. Three areas at least you remember. As we already know, bare area. Am I right? Hepatic vein, which is a caval system on portal system. Communication with caval system is inferior phrenic vein. Portocaval. Caval is portocaval. First you know the meaning so that you can understand each region. Okay. Portocaval. Porto is our system. Systemic veins. Caval is specialized vein. So there and there you get communication. At the upper end of esophagus, left gastric vein. Lower end of rectum. Superior and middle rectal vein. So if there are any portal hypertension, you get hemorrhage from this portocaval anastomosis that leads to hematemesis from the left gastric vein, if not bleeding through rectum from the middle rectal vein. You understand, right? Either vomiting if it is on the upper end, if it is on the lower part of the GIT, it is through hemorrhoids or the piles. Sometimes on the anterior abdominal wall you get a communication. If so, what can occur? You get enlargement of the veins on the anterior abdominal wall with protrusion of the umbilicus called caput medusae. Caput medusae can be seen on the and you get enlargement of the veins over the umbilical veins will be dilated on the surface of the abdomen. Okay, so you should know what is portocaval anastomosis, what are all the sites of portocaval anastomosis. Specifically, you should read this. You have to sit and read. Which is portal system, which is caval system, where it is present, clinical manifestation, what causes hematemesis, what causes caput medusae, what causes hemorrhoids. These three things you sit and do. And bare area, four things. There are so many things. These four are very, very important. Upper end of stomach, hemorrhoids on the rectum, umbilical region, bare area. This four area you sit and work it off. I think it is given on your textbook too. See on the picture. Something has been marked as red color, right? That is the left gastric vein. This is on the anterior abdominal wall. Lower down it is the rectum. Can you able to see this? Engorged veins. Can you able to see this? Yes. Now, more or less we completed the structures of the abdomen. Still, I said peritoneal organ and retroperitoneal organ. We didn't go behind, right? Retroperitoneum we didn't touch. Pancreas I didn't do, right? It is retroperitoneal. Kidney we didn't do. Ureter we didn't do. Suprarenal gland we didn't do. Those are all retroperitoneal organs. But before that, retroperitoneal organs are lodged on posterior abdominal wall. We have anterior abdominal wall muscles. We saw what are all the various layers. The muscle, rectus sheath, the rectus abdominis muscle, cremasteric reflex. Am I right? Now on the posterior wall, you get a muscle extending from the vertebra. Am I right? You see the lumbar vertebra on the center. Two muscles are extending downwards towards the lower limb. This tendon can be seen on the femoral triangle as the floor. That tendon is called psoas major. That muscle is, can you able to see that has been marked red color code and the labeling has been highlighted. Kindly look over that alone. Psoas major, which extends from the lateral surface of the bodies of the lumbar vertebra, coming towards the iliac bone, crossing the iliac bone. Already we saw this as the posterior relation of cecum also. Am I right? Now it is forming a tendon towards the insertion. That will come to it later. Next, on either side of the psoas major, one more muscle, quadratus lumborum. A quadrangular shaped muscle called as quadratus lumborum. Quadratus lumborum. With this, I will do the diaphragm also. It's very clear. The picture is the diaphragm as this is the right crest of diaphragm and this is the left crest of diaphragm. Right crest and left crest. Which crest is larger? Which crest is smaller? Right is larger, left is smaller. So right arises from L1, L2, L3. Left arises only from L1 and L2 alone. Now it ascends above, forming medial arcuate ligament and lateral arcuate ligament. Can you able to see this? The diaphragm, after making a tendinous origin, it is diverging as two folds. Am I right? One on the, this is medial, this is lateral. This is medial, this is lateral. Now you get a glistening membrane above. Am I right? So this is the medial arcuate ligament. This is the lateral arcuate ligament. This medial arcuate ligament is derived from the fascia covering the upper part of psoas major. This lateral arcuate ligament is derived from the fascia covering quadratus lumborum. You are clear with this? Am I right? We are talking about diaphragm. The tendinous insertion origin L1, L2. How many crests? Right crest, left crest. Medial arcuate ligament, lateral arcuate ligament. Medial is from the fascia covering psoas major. Lateral is from the quadratus lumborum. And we get openings. Will come to it later. Now the picture is very clear, so I told you this at this point. Okay. The posterior abdominal wall muscles are psoas major and quadratus lumborum. Quadratus lumborum. One more muscle, iliacus. Iliacus. Can you able to see iliacus? As we did the brachial plexus, here it is lumbar plexus. So the root value of the lumbar plexus is T12 to L5. T12 to L5, right? Lumbar spinal nerve, anterior spinal rami, L1, L2, L3, L4, L5 contribute to the formation of lumbar plexus. Contribute to the formation of lumbar plexus. As I already told you, anything related to T12 is called as subcostal nerve. It is called as subcostal nerve. It is called as subcostal nerve. L1 fiber gives off two branches, iliohypogastric and ilioinguinal nerve. L1 fiber gives off iliohypogastric and ilioinguinal nerve. L1 and L2 as two components, genitofemoral. Where we saw genitofemoral as a content of spermatic cord. As a content of spermatic cord. Genitofemoral nerve. So that represent it has two components, a genital component and a femoral component. Genitofemoral nerve, L1 and L2. Now you trace it down. Lateral cutaneous nerve, lateral femoral cutaneous. Am I right? It is cutaneous. Am I right? So remember, the nerves are arising in between the psoas major and iliacus muscle. That's the way how the nerve fiber will come out from the region. But what I am now discussing is the cutaneous nerve, right? It should come to the skin, lateral femoral, right? It should come to the thigh. So it comes to the anterior superior iliac spine, then it becomes cutaneous. This is important. So any compression of the anterior superior iliac spine over your hip causes compression of lateral cutaneous nerve of thigh that interrupts the area of supply of that particular area on the lateral aspect of the thigh, which is a branch from lumbar plexus. These are all cutaneous. Two more important nerve, femoral and obturator, which are the motor nerve of the thigh. Femoral nerve is going to supply the anterior compartment of the thigh, which is the extensor compartment. whereas the obturator nerve is going to supply the medial compartment of the thigh, which is the adductor compartment, having the same root value L2, L3, L4. You are clear with this, right? The root values can come in MCQs. Ilioinguinal nerve L1, iliohypogastric nerve L1, genitofemoral nerve L1 and L2, obturator and femoral L2, L3 and L4, lateral cutaneous nerve of thigh L2 and L3. As the name indicates, femoral is going to supply the anterior compartment of thigh. Extensor compartment, this anterior part, right? Here it is flexor, there it is extensor. In addition to flexor and extensor compartment of the arm, thigh has one more compartment called as medial compartment. That medial compartment is a very rudimentary or absent. Some say coracobrachialis as a medial compartment, that is a remnant. If not, we include coracobrachialis as the anterior. You add on anterior itself. Very few authors say it can be a medial compartment, but it is not so. It is pure because the action is flexion only. It is not doing any other action. So it is included on flexor compartment, on the anterior compartment of the arm. So that completes lumbar plexus. Next is suprarenal gland. What is the location of suprarenal gland? Location of suprarenal gland is above the, what we are now reading is the structures of retroperitoneal organ. Retroperitoneal organs posteriorly present. Suprarenal gland is otherwise called as adrenal gland. What is the function of adrenal gland? There are 3 layers, am I right? Is divided into outer cortex, inner medulla. Outer cortex has how many layers? Outer cortex has how many layers? 3 layers. The layers are glomerular. So what does each layer secrete? First layer secrete aldosterone. Second layer secrete cortisol. Third layer secrete androgen. Innermost layer secrete catecholamines. So you know the layer, know the secretion. This is important. First is cortex medulla. Cortex is further divided into glomerular, fasciculata, and reticularis, and the secretions. After hepatorenal pouch, we forgot to discuss that. I'll tell you what is that. We discuss. So location is on the above the kidney, on the upper pole of kidney. Kidney has an upper pole, lower pole. Upper pole, what is large? Suprarenal gland. We already discussed the arterial supply, right? Middle, suprarenal artery, branch from abdominal aorta. Superior suprarenal artery, branch from inferior phrenic artery. Inferior suprarenal artery arises from renal artery. Renal artery arises from renal artery. So know the layers, blood supply, location. That is enough. Okay. Next important organ, kidney. How many kidneys we have? 2 kidneys. Which kidney is lower? Right kidney is lower because the diaphragm is present above. Left kidney is slightly at the higher level. Okay. Now, kidney has an upper pole and lower pole. Upper pole, lower pole. Medial border, lateral border. Where the hilum is present, that is medial border. This convex border is lateral border. Anterior surface, posterior surface. Now on the anterior surface, some organs are making impressions. I can able to see on the picture, but it varies from right side and left side. It varies from right side and left side. From above downwards, you trace the impression on right side and left side. See on the picture that tells you everything. On the upper pole of right kidney, it is related to the gland. Major part of the anterior surface has relation with liver, hepatic area. Close to the ileum on the medial border, it is related to the second part of duodenum by a C-shaped impression. Lower part of the anterior surface is related to the right colic flexure. We know left colic flexure on the left side, where the transverse colon is descending down as descending colon. That is called left colic flexure, otherwise called as plane flexure, where you get the attachment of phrenicocholic ligament, which acts as the chair for the liver. Likewise, the transition between the ascending colon to transverse colon, there you get a curvature that is called right colic flexure, otherwise called hepatic flexure, which is related to the anterior surface of the right kidney on the anterior surface. Now to see the left kidney, the impression varies. Left side, above downward, near the superior suprarenal, along the margin of the lateral border colon. Am I right? Now, larger anterior surface is occupied by pancreas and jejunum. Am I right? And spleen in additionally. This you have to remember regarding kidney. So, what we expect you to know is in MCQ they will be giving some organs. What are all the organs? So, it is related to kidney. Structures related to the anterior surface are except on the left side and left side you should know. Except you should know which exception is there. If the thing is on the left side, you have to mention it is not on the left side. Jejunum is on the left side, not on the right side. Liver is on the right side, not on the left side. By that time, this is important. Is it clear? For that one, you should know the relations.